Welcome to This Explainer. If you work in anesthesiology, intensive care, or emergency medicine, you already know that airway management is absolutely paramount. Today, we're going to visually unpack a totally fundamental clinical tool, the Mallampati Score. It's used to predict exactly how difficult an airway intubation is going to be. We'll look at the anatomy, the grading, and the hidden pitfalls that can turn a routine procedure into a sudden, terrifying emergency.
So let's start with the ultimate high-stakes question. How on earth can a doctor predict a literal life-or-death intubation crisis in just 10 seconds? Because when you're securing an airway against the clock, those initial few seconds of visual assessment, they dictate absolutely everything that happens next. Here's our roadmap for today. We'll start with those life-saving 10 seconds. Define what the score actually is, walk through the 4 classes of difficulty, highlight a really dangerous mistake you can make, and finally, wrap up with the lemon algorithm for perfect clinical preparation.
All right, part 1, the life-saving 10 seconds.
To really master this tool, you've got to understand where it came from and why it was created in the first place. It all started back in 1985. An American Indian anesthesiologist, Dr. Seshagiri Mallampati, proposed a brilliant but simple 3-class system based just on oral anatomy. But, medicine is always evolving. Just 2 years later, in 1987, Samson and Young introduced a crucial modification, adding that highly dangerous Class 4. And that modified version? That is exactly what we rely on in clinical practice today. Dr. Mallampati's core hypothesis was simple, but honestly, it's profound. He said, the larger the base of the tongue and the more it obscures the pharynx, the harder it is to see the vocal cords during laryngoscopy. It basically establishes a direct, physical link between the anatomy you can see on the outside and the dangerously hidden structures on the inside. Moving on to part 2, what actually is the Mallampati score? When you ask a patient to open their mouth, you have to know exactly what you're looking for, right? Because you can't score what you can't identify. There's this rule of 4 exact anatomical markers you must mentally check off in those 10 seconds. First, the soft palate, which is just the posterior continuation of the hard palate. Second, the tonsillar pillars. Those are the folds housing the tonsils. Third, the uvula, that little hanging structure dropping from the middle of the soft palate. And finally, the hard palate itself, the bony roof of the mouth. If you don't know exactly what these 4 structures are, the classes we're about to discuss mean absolutely nothing. Which brings us to part 3, the 4 classes, from easy to difficult. Think of this scoring system as a progression of disappearing anatomy and increasing danger, starting with Class I. This is your absolute best-case scenario. When the patient opens up, the soft palate, tonsillar pillars, and the uvula are all completely, fully visible. Clinically, this means securing that airway should be a total breeze. You have a clear line of sight, predicting an easy intubation where the vocal cords will be 100% visible during laryngoscopy. Now, as we move to Class II, the anatomical picture shrinks just a bit. You can clearly see the soft palate and most of the uvula, but notice how the tonsillar pillars are now hidden by the base of the tongue. Clinically, this is still a relatively easy intubation. You might run into some minor expected difficulties getting a perfect view of the vocal cords, but there are no serious obstacles yet. Okay, pay close attention here, because Class 3 is where we shift right into the danger zone. In this class, you can only see the soft palate and the very base of the uvula. The tip of the uvula, completely gone from view. This represents a clear risk for a difficult intubation. Once you get in there with your laryngoscope, it's highly predicted that you'll only see the epiglottis, making those vocal cords incredibly hard to target. And finally, we hit Class 4. This is the ultimate giant red flashing light for an extremely difficult intubation. When you look in the mouth, the soft palate is entirely swallowed up under the massive base of the tongue. Literally only the hard palate is visible. This alerts you right away that even the epiglottis might be totally invisible during the procedure. At this stage, standard intubation is probably going to fail, and you will urgently need specialized gear like a videolaryngoscope or a bronchoscope. All right, part 4, a dangerous mistake. Let's talk technique, because even if you know those 4 classes perfectly, here is where doctors make a literal fatal error in their assessment. The patient needs to be sitting up, head in a neutral position, mouth open wide, tongue out. But the absolute golden rule, 0 phonation. The patient must never say ah. Now, you might be wondering, why in the world would a simple sound, something doctors ask patients to do all the time during a regular throat exam, lead to a catastrophic medical failure during an airway assessment? Well, here's the catch. Phonation triggers a physiological reflex that lifts the soft palate upwards. And this creates what we call false optimism. It's a deadly illusion that makes a genuinely dangerous Class 3 or 4 airway suddenly look like a perfectly safe Class 1 or 2. It completely tricks a doctor into a false sense of security, and that results in an absolute nightmare on the operating table when they suddenly, unexpectedly, cannot intubate.
It all comes down to this direct statistical correlation between the external Mallampati class and the internal Cormack-Lehane grade. If Mallampati is what you see in the pre-op chair, Cormack-Lehane is what you actually see down the blade of the laryngoscope. Class I perfectly maps to grade 1, where the vocal cords are completely open and visible. Class 2 is a partial view. Class 3 drops you down to grade 3, where you only see the epiglottis. And a Class 4, that means you hit a grade 4 internal view where absolutely nothing is visible. It's a highly predictive, direct correlation.
Finally, part 5, lemon for perfect preparation. Because let's be real, no single clinical tool is absolutely perfect, and we have to zoom back out to look at the whole patient. The Mallampati score actually only has a sensitivity of about 35 to 60%. That means it misses the mark frequently. A patient could score a Class 4 but still be easy to intubate, or conversely, a Class 1 could completely blindside you and prove difficult. Because of this sensitivity, relying solely on Mallampati just isn't enough. We need a comprehensive backup plan. And that backup plan is the Lemon algorithm. It's this incredibly structured framework that takes the Mallampati score and nests it right alongside other critical physical assessments. L is for look externally, checking for a small jaw, obesity, or a short neck. E is evaluate the 3-3-2 rule, measuring finger distances from mouth opening and neck geometry. M is our Mallampati score. O stands for obstruction, looking out for swelling, tumors, or trauma. And finally, N is neck mobility. Can the patient actually tilt their head back? This algorithm ensures total, holistic airway preparedness.
So here's your clinical survival rule. Those mere 5 to 10 seconds of visual assessment directly dictate your immediate actions. If you score a patient as a Mallampati 3 or IV, you must never attempt the intubation alone. No way. You immediately call for backup, ensure an experienced doctor is by your side, and have the difficult airway cart fully prepped and open right there in the room.
I want to leave you with one final powerful thought drawn straight from the core philosophy of airway management. A good doctor isn't just one who gets out of a difficult situation, but one who prevents it. The Mallampati score is your early warning system. So the real question is, will you use these critical 10 seconds merely to react to an airway crisis when it blows up, or will you master this visual assessment to ensure that crisis never happens at all? Keep this tool sharp, rely on the Lemon backup, and never let false optimism catch you off guard.